All right, I think we're going to move on to Dr. Razavi, if you could join us. We're going to talk about Nutcracker Syndrome, and do we need a dedicated stent for this?
Great, thank you very much for the invitation and to be here. So the premise of this topic that was given to me is that, yeah, we do need new stents, but so let's examine that. These are my disclosures. So renal vein compression, etiology is basically, you know, the anterior Nutcracker syndrome or the posterior Nutcracker syndrome or the circumaortic renal vein. And then prior transposition is also a risk factor. Symptoms, you know, in women, pelvic pain, pressure, dyspareunia, and men, symptoms of varicocele, pelvic varicosities. But the two things that frequently may not be considered initially is proteinuria and hematuria, both of which are common. Not in this entity, but they are common that they do occur. So now renal vein stent placement, not well accepted for treatment of symptomatic left renal vein compression, and the reason is because of the scant data mostly. And also an unacceptable rate of complication in early case reports. If you look at it, there was migration, embolization, misplacement, thrombosis, all sorts of complication. And there were attempted placement of wall stent in some of these in inexperienced centers, which really did not understand performance characteristics of the wall stent that does not necessarily match this particular location. Wall stent has been a good stent a long time. It works in a lot of areas, but in this particular location, the imprecise deployment, suboptimal wall apposition, it's prone to migration and variable compression resistance along its axis, where the radial force at different parts of the stent is very different. All of those means it's an inappropriate stent for this location. If you look at it, this is from actually our center. I just want to show you an example. This patient had tumor in the SVC, is compressing in the upper SVC. As you can see, that the operator, which was one of my partners, pulled the port out of the way and tried to treat this with a wall stent, which was sized to the lower SVC, and this is what happened. And you know this is not going to stay in place. And he tried to fix this by putting another stent in and fixing it, and there's a second wall stent in there, and this happened. So these are the types of features of this particular stent that makes it inappropriate for renal vein stenting. If you look at, and I put 3 examples, and the reason I put these 3 examples becomes obvious. The first one, as you can see, and they're not very early. 75 patients, but 5 migrations. Okay, that's just not acceptable to have almost, you know, over you know, something like 7-8% migration rate. Second one, Journal of Urology, 61 patients, but if you look at it now, they did have a stent embolization, migration, misplacement, but the important thing is that 20 of 60 patients had no response. That means there was a patient selection issue, that the symptoms didn't match what patient had. They just happened to have renal vein compression. However, the last paper from the Pittsburgh group is probably more reflective of the current practice. 18 patients, good symptom response, and no complication with pretty good patency. Now, indications for renal vein stenting in our practice really has evolved over the years. This is not a common procedure for us, but we've done over 60 of these. And it's a recurrent refractory symptomatic gonadal vein reflux over the past 25 years. Reflux and other causes of pelvic venous disease have to be established, or the correlation has to be established. Refractory proteinuria, refractory hemoglobinuria, and renal vein compression, pelvic venous disorder, hemoglobinuria, proteinuria, they do occur independent of each other. The correlation has to be established, and that's not always easy to do. So for us, renal vein stent placement is only done as the last step after all other causes have been ruled out. And I show you a couple of examples of those. She's a 33-year-old female with typical symptoms of pelvic venous disorder. Here's a CT. Patient had mesenteric cyst, which was a sort of distracted people for 4 years, and then they thought their symptoms were because of these. And you can see them, however, in the CTs, you can see, huge pelvic varices and the reflux in the pelvic veins. And this patient was treated by embolization. As you can see, there is a renal vein compression that we noticed, but we generally don't treat that at the same session or early on. They have to be refractory before we treat those. Symptoms went away, but they recurred, and they showed that there's more reflux. Now, this was early on in our experience, and I was still not very convinced that I should be treating that. So we did another set of embolization. Same thing happened. Okay, so patient's symptoms went away, and they came back. Now on the third one, the patient now has microhematuria. So we went ahead and treated this. We embolized all of those and put a stent in there. And as you can see, here's the smart stent in place in this location. And now the symptoms went away. Now, once again, abated completely, and pain and symptoms are minimal and have now for the past 17 years. And if you look at the imaging in this patient, now here's where the question comes in. Do we have the right stent for this location? Look at the geometry of the stent in these patients, right? In that particular location. Should we put, these, now that we have higher radial force compression resistant stents in that location, is that going to over time cause an issue with the aorta or the SMA? Or if it's a retroaortic renal vein, is that going to cause further pain? Because that's where the nerves are on top of the stent, on top of the spine. And if you have compression over time, is that going to cause problems? These are all unanswered questions. Here's the, by the way, over time, this patient actually came back for a different reason about 2 months ago, and the stent still looked the same and widely patent. Now, here's the patient, same type of symptoms, retroaortic renal vein. That communication to the tributaries of the internal iliac vein was coil embolized. Pelvic varices were taken, and everything is the way we usually treat these things, embolized all the way up to the top. This is retroaortic. Typically, again, in our practice, we don't treat these first. We wait, and then when it recurs, which this patient did, then we went ahead, afterwards, and we, after a second recurrence, we went ahead and stented those. And here's the stent. Now look at the geometry of this stent with respect to this morphology. There it is. So is that a concern? Should we have sized it differently? That was a concern to me. So we did a dyno CT on the table, and as you can see, no, it looks pretty good. No reason to worry about it, and then here's the IVUS at the point, and there is that little area of outpouching which remodeled over time. And here it is, the follow-up about 2 years later. As you can see, that area has remodeled. But again, look at where that stent sits in relation to the spine. Now, the nerves are more lateral to that location where that stent is touching. However, it could be that they may cause back pain. We just don't know. Don't know enough. Should we put more, higher compression resistance, higher radial force, larger stent in that location? I'm not convinced that that would necessarily be the case. And I worry about that. Look at the impression in that aorta anterior. Now, it turns out that I have developed a level of confidence. I was a few years ago quite worried that these nitinol stents may erode into the adjacent vessels. Now, we have had an opportunity over the years in the May-Thurner compression to look at it with IVUS, and you can see some thickening of the wall of the vein outside those stents, which adds some more comfort to me that these are not going to be an issue over time. By the way, in this particular location, there's no reason to get this far into the IVC. The point of compression is at the point which you can relieve it by just coming right to the IVC and not extend it way out there. So, renal vein characteristic is short. It's not long. It's a 90-degree angle of convergence into the IVC unless you have retroaortic or circumaortic vein. Now, stent option, balloon expandable stents, forget it. The compression endos will compress them. And I can tell you that from experience, having put these some 30 years ago, not in the renal vein, but in the iliac veins. Wall stent, for the same reason we talked about, not good. Biliary nitinol stents, they have low radial force and compression resistance. Seem to be adequate, good enough, but they're not optimal. Dedicated venous stent, they're stiff, they have large delivery systems. And with these angles as they come in, then we've done them. But I tell you, it's a work. It's a work. So desired features, in my opinion, optimal renal venous stent is a better delivery system, number one. Precise delivery, steerable sheath. It would really make life easier. Trackable lower profile. Self-expanding, I prefer open cell nitinol stents, and the reason there's less risk of migration, improved profile. You need to retain some compression resistance, and of course, dimensions should be short. 12 or 14 diameter is probably plenty in these patients. So in conclusion, it's got to be in experienced hands. You have to feel comfortable doing this. Please don't use systems that you're not comfortable with, in particular in this location. Mid and long-term outcomes remain quite scant, unfortunately. And although current generation of stents may be good enough, they're probably not optimized for this application. Thank you.
Mm-hmm.
Mahmood, just a second, if you stayed up here. I 100% agree with you, because I have removed several stents, and I have seen patients who had median sternotomy just one day after renal vein stenting. We need more than just a short, non-compressible stent. We need a stent that does not migrate, maybe with external spike or something. But migration is the danger in this.
Agree. The problem with the spikes is that it may be a unfounded concern on my part, is that you can see how close these veins are to other structure. Would that cause an issue or not? I have no idea. I don't know that, but it's something. It's a concern. I mentioned I had the concern that these stents would erode into adjacent vasculature. They didn't, so it was unfounded. It could be that, but it's something to be considered. Yeah. Thank you.
I have a quick question regarding the. Can I have the opinion of regarding this? For the incidence of migration is definitely very, very high, and my understanding is that also the transposition. You develop stricture at the anastomosis, and that's why it's not really the best. I heard a presentation last year where the specialist recommended a hybrid approach, and I believe it was from the Mayo Clinic, where you would do the transposition, and then you will place the stent and suture the stent at the anastomosis. What do you think of that?
Well,
so that seems to resolve
we reported the hybrid procedure, and certainly once you have actually a transposition, then the situation is completely different, because the vein is angling downwards, and the migration and the danger of going to the heart is very small. But yes, the hybrid procedure is the only other way at this point until we have better stents, because these current stents are simply too dangerous.